Welcome to today's webinar series. My name is Becky Sanders, and I'm the Program Director of the Upper Midwest Telehealth Resource Center. Today we have with us Kathleen Chelminiak and Bryce Ray Nelson, and they're going to talk to us about a program called the Indiana Rural Schools Clinic Network. All right, take it away.
Okay, hi guys. Good afternoon. Thanks so much for the opportunity to share what we've done with our telehealth clinic so far. Like Becky said, my name is Kathleen, and I serve as the Project Director for the Indiana Rural Schools Clinic Network, which we refer to as IRSCN. It is a network formed under the umbrella of the Indiana Rural Health Association. So the Indiana Rural Health Association, or IRHA, is a not-for-profit organization, excuse me, based out of Linton, Indiana, with the mission of improving the health of all Hoosiers in rural settings. And a huge piece of that is access to care. We house one of the telehealth resource centers, which of course you guys know because you're on this webinar, the Upper Midwest Telehealth Resource Center within IRHA. So we have a good amount of telehealth experience and knowledge. I actually inherited the IRSCN project in early 2018 and have been the project director since that time. I absolutely love what I do, as our main goals are to give kids in rural Indiana schools another way to access care in those four walls that they're in every day. We are neither a healthcare provider nor a school, but sort of a third-party provider, project manager of these services to our rural partners. And when I say rural partners in this case, I mean the providers in the schools we've partnered with in this initiative. So this all started with a HRSA planning grant that was awarded in 2015. Our intention was to simply lay the groundwork to establish a school-based telehealth network in rural Indiana. We collaborated with a state Medicaid provider, rural healthcare providers, and rural schools in establishing this plan. And while that was happening, IRHA heard there was going to be a 4-year telehealth network grant program. And it's almost as if the stars completely aligned. We ended up writing for that 4-year network grant through HRSA Office for the Advancement of Telehealth to get funding for equipment and implementation of these school-based telehealth clinics. And I'm sure it goes without saying, we were awarded that funding and started working towards establishing this network in September of 2016. During this presentation, I'm going to share with you some of our experience with implementing school-based telehealth clinics, our processes. We'll identify why we chose school-based telehealth clinics, talk about who key players are, we'll address challenges, and we'll identify how sustainable these services will be upon the grant period ending. So why telehealth? What was our interest and ultimately our decision to utilize telehealth in schools? First, it goes without saying that there is a shortage of providers in rural communities. This was a way for us to connect these rural schools to care and give these school-aged children easier access to a provider that may or may not be in their physical area. This allows students to have regular and reliable appointments where they don't have to rely on transportation or scheduling issues. And this speeds up the process of getting an appointment, diagnosis, and potential treatment. On top of that, parents that have hourly jobs or those with jobs that are a good distance away have the option to not have to leave work to be present at the appointment, nor is it on them to get them to an appointment. So their child can have access to care even if the parent is in a circumstance where they can't get them physically to a provider office. Another benefit is that it helps students establish good health practices. Kids know that if they feel funny or if their ear hurts or if they feel upset or anxious from like a behavioral health standpoint, that they're able to some degree, know that they have access to care through a physical health provider or can talk to a behavioral health provider on a regular basis. All of these services are billed to insurance, just like the visit took place at the physical location of the provider office. To bill, the provider will utilize proper CPT codes and add appropriate GT modifier and or place of service codes. It also can be more cost effective because you don't need a separate provider in the physical school location like some traditional school-based health centers do. And then finally, as mentioned before, a huge reason we chose to do telehealth is due to IRHA housing one of the 12 regional TRCs. So having experience and expertise within our organization made it easily accessible to vet equipment, identify regulations, and implement telehealth. Okay, so let's talk about some of the key players in implementing this. A critical piece of ensuring success in our school-based telehealth clinics is first identifying your key players, and then of course getting them 100% on board. It has definitely taken a village to implement these telehealth clinics. For success, it's critical to get buy-in from the school, people like the superintendent, the principals, the school nurse, and even the teachers. Parents have tended to trust teachers the most. They'll ask their opinion on it, so therefore it's critical to make sure teachers understand the telehealth clinic and that they're supportive. We recently, because of this, started offering to go to teacher meetings or in-services so they can ask questions about the telehealth clinic, so they can feel empowered and comfortable to talk about it to parents. Another key piece, of course, is ensuring that providers are totally on board. We've learned that it always works better if providers are engaged on the front end of the project, especially if they are part of a fairly large provider network. As far as funding for our specific project, we would not have been able to do this without HRSA, Office for the Advancement of Telehealth grant funding, as telehealth equipment can be costly, and staff from IRHA to manage all of the working pieces has been critical, as oftentimes these schools and providers don't have some of the resources to add any additional projects to their plate. We actually have also received funding from all 4 of the MCE's managed care entities in Indiana, and there are a few schools that have community grants to help support their efforts in implementation and expansion of telehealth clinics as well. Speaking to insurance navigators, in the communities we've been in so far, we do run into families that are uninsured. So we make sure that if the healthcare provider does not have someone in place to help with this, we have a partnership to provide support and guidance in getting those uninsured individuals signed up for insurance. We ask these navigators to be at back-to-school events, parent-teacher conferences, pretty much any event where we'll go to have access to students and parents. And finally, this kind of goes without saying, but community support is really, really huge. Many of our schools have been great about promoting this via local news, some via Facebook pages, and then of course others are able to share it to their personal pages, others at community events like fairs. IRHA can attend any of these events to help promote the program, and we do attend events at the school to promote the telehealth clinic to the school community. So as a member of the IRSCN network, you are brought into a group of rural schools and providers with the common goal of keeping students healthy and in school. Due to these grant funds, we are able to purchase telehealth equipment for around 4 to 5 new rural locations per year, depending on the services that they intend to offer. For those who are not rural, we offer assistance in various ways so we can reach areas outside of rural as well, because we understand that access to care is not only a rural concern. We offer things like technical assistance, workflow guidance, equipment training, project management, and provide checklists to complete key items. We can provide templates for consents and legal documentation, and can help members to find billing support and up-to-date information. Of course, as mentioned before, we promote the program at back-to-school events, family fun nights, parent-teacher nights, attend events around the state where we'll touch these rural communities. And then when the clinic is ready to launch, we actually put on a ribbon cutting with the school and provider and are able to get TV news, local papers, statewide coverage. And that's just another way to get the word out about the telehealth clinic. Another benefit of being part of our network is having the ability to be part of a network of other school-based telehealth clinics. We have networking calls, and we will also connect new clinics to established clinics via calls or emails or site visits to share experiences and answer any questions. As you would assume, this has been incredibly valuable to our members to have the opportunity to connect with those already established clinics, bounce ideas and experiences off of each other. And then, of course, data collection is another piece that we offer. And Bryce, who is also presenting, will talk about this later in the presentation. Okay, so moving on to the product of all of this background, our telehealth clinics. We are currently about halfway through our third year of funding. Again, we do have 4 years of funding. And here you can see our live school and provider partnerships. And you can also see from this map that we are all over the state. As of March 2019, we have 16 live rural school-based telehealth clinic locations. We did have to pull equipment from one clinic due to lack of utilization, which we'll talk about later. By the end of the 2018-2019 school year, we plan to launch 2 more telehealth clinics. By August 2019, we'll be launching 3 more. And at the end of this March, we will be accepting our year 4 cohort, which will be 5 additional school and provider partnerships. To speak to the process of those who have applied and will apply, the first step in becoming part of the IRSCN network is for a provider and a school to establish a relationship with the intentions to open a telehealth clinic. They will fill out an application on the IRSCN site so that we can get some key information from them to determine if they would be a good fit for this grant funding. We work with established partnerships of local rural schools and providers in Indiana, those who have a full-time school nurse, generally those who are 50% or around 50% free and reduced lunch populations, and healthcare providers who have contracts with all 4 Indiana Medicaid providers. So before we move into what our workflow looks like as far as our telehealth clinics, I wanted to take a second to identify what telehealth looks like for us. Of course, the originating site is where the patient is, and that's the school. The school nurse is acting as the presenter, and the distant site is the provider office where that provider is. The telehealth solution we use to connect the schools to a remote provider are web-based platforms with equipment and software installed on the school side. All solutions we utilize in our clinics have attachments that the nurse or the presenter utilizes to act as the remote provider's hands, per se. They include a general exam lens, a dermoscope, an otoscope, and a stethoscope, which are pictured here. You can see it on the line between the originating and the distant site. To briefly touch on billing as far as our telehealth clinics go, in the past, Indiana Medicaid reimbursement manual listed schools as an originating site that didn't have the ability to bill an originating site fee, though if you're in another state, that's something to look into. This verbiage has actually since been removed from the manual, and IRHA is currently just waiting to see a final updated version of this provider manual so we can begin sharing this with our school sites with confidence that they will indeed be eligible for reimbursement as an originating site. With this, we hope that schools would be able to offset some of the costs of providing care for these kids. Providers, however, are able to bill for the service. Again, it's billed like a normal office visit with the appropriate GT and or place of service codes attached. So just to talk about where this all began, again, we're in 16 school sites and we utilize 10 provider groups across the state. As far as the grant goes, we don't have a preference for what telehealth solution our schools use, but we do, of course, review any technology that they decide to use. We require that it's HIPAA compliant video conferencing and has appropriate peripheral devices to help the provider, the remote provider, in diagnosing the student. We do start off the majority of our schools with the ability to provide acute physical care because there is such a strong correlation between physical well-being and mental well-being. My husband is an assistant principal at a school in Indiana, and oftentimes kids are acting out just because the physical health need hasn't been met. So the intersection between all of this is so important for the overall services in our school-based telehealth clinics. Our initial launch includes services for those acute physical illnesses that are common among school-age children. So things like flu, strep throat, ear infection, pink eye, lice, rash, just those common school illnesses. This slide's pretty self-explanatory. It's just a list of those physical health providers that we're currently utilizing. Again, we have 10 physical health providers, and you can see that they range all the way from critical access to RHCs, FQHCs, and rural hospitals. So what that physical health process looks like: when the child presents to the school nurse will determine if the child would benefit from utilizing the telehealth clinic. We like to stress that this is not to take the place of what the nurse normally does. He or she will follow their normal workflow for any scratches, rashes, stuffy noses, the infamous bruise that might need a Band-Aid as normal. The telehealth clinic is only used when the school nurse deems that it is appropriate and helpful to utilize. So, for example, if the child presented and was identifying that they had ear pain, the nurse in this case could determine if the child should see a provider. First, the nurse is going to check to see if there's a consent form on file. They'll then call the parent, get a second verbal consent. The parent can opt to either have their child seen with or without their presence, or not have them seen in this manner. They then schedule with the provider office, and soon after are able to see the provider at the designated time. The nurse will utilize those telehealth attachments that we saw in a previous slide, acting as the provider's hands. In the case of in the case of ear pain, the otoscope would be helpful in diagnosis of a potential ear infection. After the provider on the distant side sees everything that they need to see, they make a diagnosis. They can call in a prescription if necessary. The parent is notified of the result of the visit, and the child is either sent home or back to class based on the diagnosis. If a prescription is called in, the parent can pick the prescription up at the pharmacy on the way home. That's something that they let them know on the front end is the pharmacy of choice. And the provider will also send over any necessary information to that child's primary care provider if they aren't already in that same EHR or physician network. In addition to offering acute care services, after these clinics are comfortable in the operations, we do move into working with the school to offer one additional service, which we determine with the school. They can offer one or more of these following services. So they can do behavioral health services and/or assessments, asthma management, diabetes management, weight management, or teledental. Thus far, all have opted to offer behavioral health services, which is telling to the great need for behavioral care, and again, why we chose telehealth for greater access. We currently have behavioral health services in 7 schools utilizing 4 different behavioral health care providers. These providers are fairly close distance-wise to their respective schools. The school and the provider do these visits via HIPAA-compliant video conferencing technology. While you could technically do telebehavioral with the physical health equipment that we provide, we wanted to make the behavioral health as cost-effective as possible and easily replicable. It became really apparent that getting a HIPAA-compliant version of a web-based platform that IRHA utilizes for meetings would work better for the behavioral health visit purposes. And this is just because it's really, really easy to set up. The patient is able to connect via a link from the provider, from a laptop, really from any device. But in this case, at the school, they do it from a specific laptop that we provide them to only be used for behavioral health services. Again, we decided on this technology because we were very familiar with it from an organizational standpoint, and there was very little barrier to cost and implementation. It's also really easy to add accounts. It is HIPAA compliant, and each location does have their own account to prevent any overlap in appointments or intercepting of appointments, stuff like that. Here we have a list of our behavioral health providers. Again, we're currently utilizing 4 entities, but are hoping to expand over this next year. Therapy is being provided for things like separation anxiety, ADHA, ODD, major depressive disorder, generalized anxiety disorder, and PTSD. All 4 of these sites offer screenings. 3 offer therapy. The one that's not able to offer therapy at this time is due to staff turnover, and they currently just don't have the capacity to offer anything but screenings and then inpatient treatment if it is appropriate. We are always looking for more behavioral health providers, and of course those that are specifically credentialed to practice in Indiana, especially since there's been some legislation passed with the goals of suicide awareness and prevention in schools. To speak a little bit about what the behavioral health visit process looks like, there is a self-parent or school referral for new patients. The parent will then call the behavioral health provider to request telebehavioral services. The child and the parent will go to the behavioral health physical location, or the behavioral health provider can go to the school to do the initial face-to-face intake assessment. This allows for the provider to determine if telebehavioral is appropriate for a new patient. If it's deemed appropriate, therapy is provided via telehealth in a designated private area of the school, and students are given a generic hall pass during non-core classes to go to regular telehealth appointments. As far as how providers thus far have determined who will utilize these services, they tend to look for kids comfortable talking to screens. In the technology age, we've often found that kids can be more comfortable talking to screens. I did hear a story from one of our providers that they weren't really getting anywhere with a particular patient, but when it was done via a screen, the patient did start opening up a little bit more and more. We love success stories like that. And I don't say that to say that it's right for everyone, and this isn't meant to take the place of any other form of care. It's just meant to provide another option and greater access to care that might work better in different areas and for different individuals. To add on to that, we'll look for kids with those mid-level behavioral health concerns in hopes that they can catch kids here before anything would potentially get worse. And then finally, some of our behavioral health providers have had a lot of success with looking through their current patient loads for those patients that frequently miss appointments, might be due to something like a lack of transportation. This is one of the easiest places to start because they have already had those face-to-face visits and have had the ability to determine if teletherapy would be beneficial. They also already have consent to treat, so they just have to get a telehealth consent from the parent. So now that you have an idea of what the program is and the services that have been provided so far to our schools, Bryce is going to move into our data collection.
All right, good afternoon, everybody. Thank you so much for joining us. My name is Bryce Ray Nelson. I am the project coordinator for the Indiana Rural Schools Clinic Network. And so I do a lot of our data collection, our data processing, and I have a great amount of communication with the nurses and our healthcare partners in order to collect that every month. So on this slide, you will kind of get a brief overview of what our data collection looks like for the 3 years that we have been operational. So in the first grant year for primary care, we had 107 total visits. In year 2, that went up to 249. And so far, in year 3, we've had 180. And so we're very impressed with this. Just I mean, just to think that we're not even halfway through our third year, and we are already above what we had in our first year. And so we're very excited to see what that number is when we end our third year in August. For our behavioral health care, in our first year, we had 27 total visits. That went up to 75 in the second year, and that went up to 118 so far this year, with that number expected to grow significantly by the end of this year. So in total, so far, we've had 536 primary care visits. For behavioral health care, we've had 220. And then total visits, both behavioral and primary care, we've had 756 visits in less than 3 full years of being operational. Next slide, Kathleen. Thank you. And so this is our physical care utilization growth by year. And so on the bottom, you can see it shows years 1, 2, and 3. And so between year 1 and 2, there was astronomical growth. And once year 3 is over, we expect the same, if not better, results. Next slide. Thank you. So between year 1 and year 2, there was a 233% increase in acute physical telehealth usage. And of course, you kind of have to ask yourself, okay, so why the growth? Why the big change in usage? We have increased the number of our clinics, and our communities have gotten increasingly comfortable with the idea of telehealth. When you introduce something like this to a small, close-knit community, sometimes there's some apprehension about that. But the good thing is that through advertising, through the efforts of the IRHA, in conjunction with the efforts of the school and our healthcare providers, we're able to better explain the services that we're able to offer. And a lot of times we are able to gain the trust of those communities and help reassure them that we are there to help increase access and increase the health of their students and their community. Between year 1 and 3, and this is current as of February of this year, there's been a 110% increase in services. And as I said before, that's expected to increase as well. We currently have 16 clinics open, and we have continued to increase access to these services in rural communities. So we're very excited about that. Next slide. And as you can see, behavioral care is doing wonderfully. It has gained so much acceptance in the communities and a lot of acceptance just in the schools in general. As Kathleen has mentioned in previous slides, students are able to stay in school. They're able to leave a non-core class, and they're able to actually have their appointment. And so this is convenient not only for the student, but also for the families, where a lot of these parents or guardians are going to work probably about 40 to 50 miles outside of town. So they're able to stay at work, and their children are still able to receive the care that they so very much need. So we expect year 3 to grow astronomically as well. Kathleen, next slide. We have seen a great increase just even between the first and second year. As you can see on there, we had a 278% increase between year 1 and year 2. And then year 2 to year 3, we had a 157% increase. And then between year 1 to year 3, it's a total of a 437% increase, which is incredible. And it just kind of shows that telehealth is a wonderful way to supplement primary care and behavioral health care. And so we do hope that these results continue to show our communities, that we continue to get inquiries from, that these services are helpful and that they do work. And I think that the usage that we've seen and the increase in usage that we've seen is a great indicator of that. Next slide.
Awesome. Thanks, Bryce. I could not have said any of that better, so I'll leave it at that.
All right.
So as we near the end of the presentation, I think we would be remiss if we didn't identify some of our challenges. As mentioned earlier in the presentation, we have had one school clinic close due to lack of utilization of the clinic. The reason for this was due to lack of a school nurse or a designated healthcare professional in that school. We worked with the school as they looked into hiring a nurse part-time, but logistically it didn't end up working out, as you clearly can't predict when a child will become ill, and it was hard to find someone that would function in that school nurse or healthcare professional role who fit the bill of that part-time job. Shortage of behavioral health providers, this kind of goes without saying. Even if we have a school that's interested, we oftentimes do have to seek out behavioral health providers for them to utilize, and this can really be a challenge. We're actually in this situation right now with one of our sites and are kind of trying to find a provider that is near them that they could utilize. And again, as we talked about earlier, we have had one behavioral health provider that did intend to offer services, and then they had staff turnover, which led to not being able to provide therapy via telehealth. To tack on to that, skepticism on behavioral health. I think sometimes kids or parents can just be skeptical to partaking in quote unquote behavioral health services. And I think all of us have seen that, and we just have to continue to normalize behavioral health needs and services, which I do feel that this program is working towards that. Of course, challenges with IT. It can take a while if the school IT doesn't have a ton of experience with sorting out firewalls. Additionally, with large hospital systems, you oftentimes have to go through many individuals before you get IT requests approved. This has caused some delay in getting schools connected to our providers, and then after all of that's done, your school IT and provider IT have to dedicate time to connect, get through the school and the provider firewalls, etc. Sometimes it is totally seamless and it goes so smoothly, and just other times it's not. Staff turnover has been somewhat of a challenge for us in the 2.5, 3 years that we've been running this program. With school nurses and providers, turnover can be very difficult because you have to make sure that this new staff member is willing to do this. They're willing to go through the whole training process as they're also getting used to their new role. And that does take a lot of time. And then the same goes for any turnover in our organization or the implementers. Staff turnover can cause some little bumps in the road and slow down some of that progress. As mentioned earlier, for our sites, when the grant started, the schools were listed as sites that couldn't bill. In the Medicaid manual, the sense has been removed. So again, we're waiting to see the updated final version. No payment has made it a little bit tough. Not incredibly tough, but just that we have had some pushback from school leadership that asks, we're already adding on to the school nurse's already busy day. There isn't really much in it for the school from a payment perspective, and it's more than understandable that this is something that we've had to address. And we always do have to come back that, and the schools do get here that it's 100% for the kids, and in the long run, it could keep those habitual users out of the school nurse's office as often due to access to care, diagnosis, and hopefully treatment. And this would also hopefully help with the spread of the illnesses that are being diagnosed. So these are a few of the challenges we've seen. We've worked through them and will continue to work through them as they come up. All right, we're almost done. So sustainability as far as our grant-funded projects goes is huge. To be sustainable in this case, there certainly needs to be buy-in from the school nurse and the provider, which we are so lucky to have strong buy-in from most of our clinics, and I'm confident that they will continue on after the grant period ends. Both the already launched behavioral health and physical health models are very sustainable for both the school and the healthcare provider, because those upfront costs of equipment, they're covered by the grant. We have tossed around ways to make sure this equipment is kept up to date, and those utilizing the equipment can continue to get support and troubleshooting from our telehealth solution vendors. We've landed on a few agreement options between the provider and the school to be able to continue to provide funds toward this. And again, the providers are able to bill for this service, which adds to that sustainability. MCE participation, again, managed care entities is what that stands for. And we have attained buy-in from all 4 MCEs in Indiana, and they provide their support in various ways. Some fund equipment, others fund equipment, and also provide some staff time for implementations, development, and sustainability. We're hoping that in the future we can continue to get support for the school-based telehealth clinics from these managed care entities. Because of the avenue that we've gone with behavioral teletherapy, again, the behavioral upfront costs are quite low. So we definitely see that being something that the school and the provider could continue to purchase and implement quite easily after completion of the grant funding. We see marketing here. So marketing is a huge piece of sustainability for these school-based telehealth clinics. And the provider or a provider rep should continue to go to some of the school events, whether that's back to school night or another school event where they would have access to be able to inform parents, answer any questions, and just have the provider there to continue to establish trust and buy-in. And then finally, as far as our sustainability, IRHA's sustainability, as mentioned, we're looking into continuing to partner with the MCEs to get funding for equipment, look for other opportunities in the state for funding, and also begin to help with any consulting services so that others could launch school-based telehealth clinics as well. Okay, thanks everyone for listening to us share with you what we do every day in rural Indiana schools. I absolutely love it. If you have any questions or are interested in becoming part of our network, please don't hesitate to reach out.
All right, thank you so much, guys. I am going to go ahead and start our question and answer time. We do have one question, and Bryce, this was for you. I thought maybe you'd get to it, so I didn't stop you. For data collection, can you reference the number of schools enrolled by school year compared to the number of primary care visits?
Yes, currently we do not have that number, but if I believe, Kathleen, we started off with, in the first year,
Yep.
5 to 6 schools, is that
Yep.
correct?
Yep,
Okay.
I can speak to that a little bit. So we had 6 schools that were in that year 1, I believe. In August, starting August of 2018, we doubled that number. So pretty much since August 2018 is when we went from 6 to 16 in this, basically between year 2 and year 3.
Great, thank you. So the line is open for additional questions. Thank you guys. I hadn't seen the latest data in your year 3 visits. That's astounding. How much it's grown is just amazing, considering we're not even done with the first quarter of 2019.
Yeah, thanks, Becky.
Yes.
I know our program was was a very unique program when we wrote for it, because we had partnerships with all of the Medicaid contracted entities in the state of Indiana. Can you just talk about that a little bit, how those partnerships work?
Yep, so it works a little bit differently with all 4. So with 2 of them, we actually have agreements in place where they provide funding for equipment, but then also will go out to these school sites with us and implement alongside us. And then with the other, so again, we have 4 MCEs. With the other 2, we just got funding for equipment. So essentially they provided X amount of dollars for this many pieces of equipment. And then of course there were certain areas where they were interested in getting greater access to care and some more data on what utilization would look like in those areas. So those partnerships are, they change a little bit between all the agreements. There might be different data pieces that they might want to grab, or different processes that we might want to go through, different services they want to offer, whether that's physical, behavioral, asthma, diabetes. But so far, that's what it's essentially looked like, is funding and support.
Mm-hmm. So the questions are starting to come in now. Have you had any community colleges participating in the behavioral health services, meaning they often need behavioral health services for their students?
We have not had any community colleges participate so far. That's a good question. That could be something that we potentially, I guess, look into in the future and as we continue to expand and move forward.
Mm-hmm. What is the program or solution you're using with the mental health sites?
Also a good question. We are utilizing HIPAA compliant Zoom.
How much percentage change has been made per site rather than aggregate?
I am not sure if we have that. Bryce, do we have that?
We do not, but it is a great question and something that would be very good to track, and that would be very easy to do. I assume that, of course it's different for every site, because something that also factors into that is, okay, so say there might be an issue with a computer 1 month, so that's going to change the percent change for that site. But that's a very good question, and it's something that I would like to look at, definitely.
So if someone really wanted an answer to that question, they could email you at the email address on the screen?
Yes, absolutely. I would be more than happy to answer any questions that they send my way.
Okay. Can you guys talk about some of what I'm sure you kind of have in your head that some sites have done really well and had better uptake on utilization, and then others less. What are some of the marketing or communication things that schools and parents have done in schools where it's really worked very well and there's been a lot of adoption?
So the schools that I've seen it work the best are where the school nurse is really vocal about it on the front end. And what this kind of looks like is just as they're in contact with the parents, they're sharing it. They're the face of this program. They're the ones that are acting as the provider's hands. So that is a huge way that the information gets to the parents. In another school, their main form of communication with their parents, I think I mentioned this in the presentation, but it was actually their school Facebook page. And so I could look at it now, but there were a huge amount of shares from their Facebook page after they posted a video when we were doing a training on the equipment. And they, I think, had, like 80% of their school sign up and say, yes, we consent to this service. And again, that's because they have that good relationship with the school nurse. They have that good relationship with that local provider. And then additionally, I know I mentioned the ribbon cuttings. With those ribbon cuttings, oftentimes are local news or local papers or radio or something like that will attend. And that has been really helpful in getting buy-in from the community as well. I would say the biggest successes come from when the school nurse is really championing, is that a word? The program.
Very good. We had a question for a copy of the PowerPoint. How do you want to make that available, Kathleen? Do you want to have them email you or email me?
Yeah, either works for me. I didn't know, are we just sharing the presentation on the...
On the YouTube page, I don't know how to share the PowerPoint, and I mean, it'd be easier just to email it. We don't have it set up on our website to have that kind of stuff, so.
Okay. It either works for me.
Okay. Let's see, where do we want to go next? Oh, this is an interesting one that I think when we first started this program, we talked about, which is really hard, I think, to do. Are they tracking academic outcomes in addition to utilization rates?
That is something that we have discussed over the past few months. You know, the Indiana Department of Education actually makes all of their data for the previous school years public. And so we have been able to track things such as attendance percentages, attendance rates, and so on and so forth. And we are keeping track of that. Now, performance rates are a little bit different. Those are a little more tricky because, you know, coming from a data standpoint, who's to say that the test scores went up because of the clinic and the attendance rate increase, or, you know, because they got 15 new tutors that come in every single week and work with the students one-on-one, you know, and so unless we know every specific change that the school district is making, it's very difficult to find a correlation between things such as the annual performance rating, the I-STEP scores, you know, things along those lines. It's very difficult to connect those.
Have you been able to connect the attendance data?
The attendance data, we are currently working on that. You know, 2 years of data really isn't a lot, with a majority of our schools being introduced at the end of last year and the beginning of this year. You know, that's something that we would have to track, I would say, at least until the end of the program to really notice a change, definitely. But that, I mean, that's a great question. That's something that we have, Kathleen and myself have been discussing for many months, definitely.
Mm-hmm.
Yeah, I think the other tracking thing that some school telehealth programs have tried to track is the any decrease in ED utilization. And again, I know that's hard to do. How are you guys approaching that?
So that is a very interesting, an interesting point. You know, one of the things that is being collected in our data now, currently, is what, you know, which provider would a student have used if they did not have access to telehealth. And so that we have kind of like a few options for them to choose from. So would they have gone and seen a primary care provider or their family doctor? Would they have seen a specialist for their visit? Or would they have gone to an emergency department or an urgent care? And so that is going to help us track that, I believe. It's, you know, it's one of those data points that's also a little difficult to collect, because then if you don't have the partnership with, say, the local emergency room, you know, you have to enter into contracts and everything else to get them to share data, because that's sensitive data, and then you have to have your HIPAA compliant method of transmission. So we're hoping that with us tracking who they would have normally seen, then we would be able to see how that's changing in the community.
Yeah, cool. Here's another question. Is there a specific tool used to assess whether a patient is viable to have a telehealth visit, or just the 3 criteria mentioned in the presentation?
Yep, that's a good question. So it really is dependent on the behavioral health provider. I know there's a variety of tools that they use for like intake. I don't remember what exactly the tools are called. One created their own. Another uses one that, you know, is a normal intake tool for behavioral health. Those 3 items that I mentioned were just some of the easy kind of lower hanging fruit so that they could start getting appointments for children that really needed it that might not be getting it otherwise.
Mm-hmm. Yeah. And this is a very similar question, but I think maybe a slightly different question. Wondering what types of mental health assessments were actually completed via video conference?
That, again, would be a question I would have to go ask our behavioral health providers. They're the ones that do all of those assessments, and I know they've told me what they use. I really should have written it down, but I don't know that answer. I can find it out, though.
Okay. So for that person, if you want, go ahead and shoot Kathleen an email so she can follow up with you. And then this is the last question I have right now, even though we still do have a few more minutes. I'll read it. So is it correct in the understanding that telehealth responsibilities were added to the school nurse function? Question mark. How has this been received?
Yep, so that is correct. Overall, it's been received fairly well. There have been, of course, in my initial meetings, school nurses do have a lot of questions on what utilization looks like. Generally speaking, per month, on average, it's about 6 students seen per month. So it's not like every time a student comes in and has, like their throat hurts or something like that, you're going to say, okay, we're going to utilize telehealth. It really is up to the school nurse to determine if it's appropriate to use. We haven't had anyone come back and say that they're completely overwhelmed. And then to add on to that, we usually recommend that they only start with one school. So like they either start with elementary, middle, or high, so that they can kind of get an idea of what it's going to add to their workload. But yes, that is correct. The school nurses are having this added on to their normal day-to-day. But again, that average is about 6 visits per month. And when we've been to a lot of these schools, I would say probably 75% of these schools have had the school nurses really championing this for their school, wanting this for their students. That's from what a lot of them have told me. That's why they're in the job that they're in, because they're really passionate about making sure these kids in school are staying healthy.
Mm-hmm. Yeah, thank you. I am going to go ahead and put the webinar survey in our chat function. If you would please answer those couple of questions. We'll just take just a minute or two. Again, thank you, Kathleen. Thank you, Bryce, for hosting us today and sharing your knowledge with us. Any last questions? Here's a good one. Are the provider partners holding appointments for these services and for the schools?
Do you mean, are they setting aside appointments?
Yes. Are they blocking time out of their day?
Good question. So most of them so far do not, just because the visit is so efficient with the school nurse on the other end, putting a lot of that information in on the front end. Generally speaking, visits only take about 10 minutes, 15 minutes on the long side of a visit. So what happens is they'll normally fit them in somewhere in their schedule. Some providers have normal sick visits open during certain days. And then if utilization is to a point where they should have a certain slot, like 30 minutes a day or an hour a day or something like that blocked out, then providers will do that. But most of them just fit them in as they come. And again, we do have we have a partnership with in one of the counties that's near where I live, and they use a few different practices. So they will go to whoever has an opening. So sometimes there's more than one provider available. Other times, if there's only one available, it can be beneficial to have a 30-minute time slot during a busier season cut out for telehealth visits.
Great, thank you. All right, that's all the questions that we have for today. Last call for questions. Bryce and Kathleen, were there any other things that you've thought of as we're going through questions that you didn't mention during your presentation?
I don't think so. Just if anyone has any other questions that come up, feel free to reach out to either Bryce or myself.
Yep, absolutely.
All right. Well, thank you everyone for your time today, and enjoy the rest of your week.
Thanks, Becky.
Thank you, Becky.